Welcome everybody to Pharmacy Grand Grams. This is our last session before we break for the summer, so thank you for coming. I'm Heather, the Pharmacy Research and Education Coordinator, and today I'm happy to introduce Debbie Bose to all of you. Debbie is a public health nurse, has been in the immunization department for 15 years, so lots of experience and knowledge. She's going to show us today on immunization. I'll hand it over to you, Debbie.
Okay, thank you. Thanks for having me today. We love to come and talk about immunization and spread our word. So, as Heather mentioned, I've been with immunization about 14 years. I've been with public health for 19. And currently, I'm in a role of Horizon Program Lead for immunization. So we're going to be working towards different things with accreditation and trying to spread the word a little bit about vaccine hesitancy also in the next year or two, and trying to get everyone talking the same language that way. One of the things that came up when we, of course, had our measles, we do have vaccine hesitancy, and it's for different reasons. Some are just myths and misconceptions out there about the vaccine. Other things we worry about are if the vaccine isn't effective, so if it isn't stored properly, and that's one of the things I'll talk about today is storage and handling, that can affect the effectiveness, and then of course that the vaccine isn't working like we're expecting, it does result in the population having a little doubt in that vaccine and maybe not so eager to be vaccinated. We know the vaccine, something like measles, is 97-98% effective, so we do expect really good immunity results from it. And with our outbreak, we felt that was evident. We had a fairly large group exposed at one of the large high schools, and when we looked at the spread in that school, it was less than 2 to 3%. So most were immunized when we did the record test, which took some time, but most people do get their MMR vaccine. They've been around for a long time. So we did see a few people with the 2 doses that did have mild illness. So they did get a diagnosis of measles, but it was much less severe, and it didn't seem to spread from those individuals. So that was good news, that they probably were not shedding the virus as much, and so the transmission didn't happen past that third group. Were some students mostly that were immunized. All right, so if you do have questions as we go along, certainly feel free to stop me and ask. All right. Do that. Perfect. All right, so one of the things that immunization providers get used to doing, we do need to learn our rules and our products and things, but we really do rely on our resources because things change with research, and we're always looking up the most recent information. So we do have, like I said, a knowledge base that we memorize a certain amount of stuff, but we're always double checking to make sure it hasn't changed. So one of the big things that we use in Canada is the Canadian Immunization Guide. The nurses at public health or any of the immunization providers would be used to going on there. They'd be pretty familiar with the chapters, where to find their things. There's numerous chapters to it, and there's one that's just general considerations. Then there's another chapter that is vaccine safety. There's one on active vaccines, which is all the different types of vaccines we give. So that's one we would visit a lot. Special populations, so that's people immunocompromised, pregnancy, travelers, healthcare workers, everyone that needs maybe a little extra vaccine or a little more required proof. And then there's also the part for the passive, so that would be immune globulins, things like that. So as I mentioned, in public health, we all sort of have it on our favorites. We don't print it off because it does change, but it does have all the most current information, and it drives it from the NACI statement. So the NACI statements are what comes out with each product, the recommendations across Canada, what should be recommended, and then the Canadian Immunization Guide sort of pulls that information in. So from the immunization guide, that leads us to where we want to recommend vaccines and who should receive them and who can and cannot, contraindications, things like that. But we also have our New Brunswick immunization guide. So that tells us who gets what for free, where you might find forms if you were looking for forms. It's all the local New Brunswick thing. So sometimes something might be recommended in Canadian Immunization Guide, but maybe it's not free, it's not part of our eligibility. We would still recommend it to someone, but they might have to do a private pay. And that would be something like a travel vaccine. And occasionally something for a medical reason, but the province is pretty good about trying to get most of that stuff covered for people. But on occasion, it does take a little time. So sometimes there might be something recommended. And an example would be like an HPV for an older female. We've started at a certain age. They can get it up to age 25 at this point, but it is recommended for females up to 45. So it's not free for everyone, unfortunately, and that's just because of the budgets and things that we do have to keep in mind when we're choosing immunizations. So there are two of the main ones we use, but we do use other resources. Another good one is immunize.ca, and that's something that parents can use too, or the public. And it has things on like posters and resources, things you might print out. Also has things on pain management, which we do try to promote, so that the pain is another reason why people get vaccine hesitant. They're concerned about the pain associated with it. Things. So that is another Canadian site that we use a fair bit. There's a new one coming out. I believe it is on the web now. It's called CanVax. And that's going to be one-stop shopping for healthcare professionals who are looking for things for vaccines. And it was presented at the Canadian Immunization Conference this year, and it's just rolling out. So it's going to have like the immunization.ca and other things all tied into it. So I think that'll be the main hub we'll probably get used to using. And it is a really nice site if someone gets familiar with it and starts to know where to go in it. So one of the first things I thought I'd talk about was the cold chain, and that's related to the vaccine storage and supply. So one of the things they always look at with accreditation, and I imagine in the pharmacy department it would be similar, would be the vaccine storage and the cold chain, making sure it's not broke with the vaccine. So we do know that if it's not kept at the proper temperature, it can lose effectiveness. So we don't want to be giving people vaccines that aren't as effective as they could be. If it warms up, sometimes it's still usable. It looks at how long and how high the temperature was at, and then it can be cumulative too. So some vaccines might be okay for 24 hours at a room temperature, but it was something that if you did have a breach and it was left out on a counter or something, you would look in the product monograph, or you could call the company and find out if it's still usable. And we would want everything to be kept in the cold chain. Like I said, we don't want waste if it could be reused, but we would normally call the company if it did happen to get left out on the counter or exposed some other way. Freezing can happen as well, which is worse. Usually if it freezes, we would discard that vaccine. We'd go ahead and call the company to be sure, but there's very little vaccine that will stay the same composition and things with it frozen, so usually they would be discarded. And as much as we don't like to see them be discarded, we'd rather that than someone get a vaccine that wasn't as effective. So when we do have our vaccines, I'm sure things at the hospital probably are all monitored for the 2 to 8 degrees. That's true with wherever you supply or store your vaccine. So fridges are all set at 2 to 8, and even all our immunization partners are aware of that. So they would have little monitors on their fridges to make sure it stays within that. When we're going out to do our community clinics or school clinics, we do have little monitors that alarm if it goes outside of that range. We do pack it with our ice, and always a refrigerated layer between your ice and your vaccine so it doesn't freeze. So when you're in the hospital or public health, we are supposed to check our vaccine temperatures twice a day. At public health, we have it logged in that it logs every 10 minutes for us, but even they still want us checking just to be sure in case that system broke down. We have a system there because we do have so much vaccine that if it does go out of range at all on the weekends and things, it phones out to the cell phone, and we have someone on call that will go in and correct that problem. And here, I'm sure it's the backup battery, so you wouldn't probably run into that issue. But on occasion, and I think last year CM Depot even had a little bit of a breach. There was some renovations going on, I think, and it was supposed to be the backup battery, so it was only maybe a 7-minute breach or something. But when that happens, it does get identified on the vaccine. So if it had a second breach, that is a different call to the pharmacy or the pharmaceutical company just to see if that vaccine's still okay. So the accreditation standards say it should be checked by a person twice a day. So in pharmacy, in the hospital, that would be a doable thing that's staffed 7 days a week. So that would be something, if you're not doing it already, it would be something that accreditation certainly would be looking forward for. When we had our accreditation this year, they always ask us about our partners and what they're doing, and we know within Horizon, we're all sort of sharing information and doing the same thing. And then we also try to share the information with our providers out in the communities, with the nurse practitioners, the doctors, or any local pharmacy and things that are giving vaccines as well. So when we do transport, and I don't know if you guys are ever needing to transport or if you ever would lend to others' hospitals or anything like that, but we do on occasion if Serum Depot is closed, if someone needs something. So, and then of course for all our clinics. But if you did, you would want to have a cooler, and you'd want to have that little thermometer that goes with it to make sure it stays in the 2 to 8. And we do put vaccine, we do put ice packs, and then like I mentioned, a refrigerated pack, and your vaccine goes in the middle.
With me?
Something wrong with that thing.
Yeah, I'm gonna send a quick email.
I think one of our sites may be off page. You're good.
Okay. All right. So this is just a little picture that comes on a magnet, and we have it on our fridge, and it just gives you all those little rules. So you only put vaccine in a refrigerator. I'm not sure if that's what happens here or if it would be added with medications. But the typical rule is only vaccine, so no food or lunches or anything like that, because it would change that temperature possibly. We stock the vaccine on a first in, first use basis so that we're always rotating it. We keep in mind the expiry dates too, so if you did get something that was less of an expiry date, it's going to expire sooner, you would probably use that first. But otherwise it's first in, first out. We never leave the vaccine outside the refrigerator. We store full bottles of water on empty shelves, and that just maintains that steady temperature better if the fridge isn't full. If your fridge is full, then you're fine. Check and log the temperature twice a day. Open the door only when necessary, and we don't leave it open, longer. If we're doing a count or something, we try to do it through the door or take it out and then do your count. Keep your vaccine between 2 and 8. Don't store vaccine on door shelves because that would be a little warmer as well. And then stock only a 1 month supply. That's our general rule within the community. Not sure with the hospital if you would have extra, and where you do have that backup battery, and you're really not going to lose power. If someone's going to lose power and they've got a year's worth of supply, it would be a lot of wastage and things like that. So that is where that rule comes from, I believe. Any questions or anything about storage and handling? So the other thing that was suggested I talk about, there were 4 little topics. So one was adult immunizations. So most people get their routine immunizations as a child, and if you do go on the New Brunswick immunization guide, there's a link there that tells what is the current vaccines. And we've added vaccines. The most recent one is the rotavirus for the babies. So each time the province adds a new vaccine, they update that schedule. We do try to get it out to people. But one of the things that adults would get on top of this would be Tdap, your tetanus, diphtheria, pertussis. So TD should be given every 10 years. 1 dose in adulthood should be a Tdap. So as a baby or a young child, you've probably had at least 4 or 5 doses of tetanus, diphtheria, whooping cough, plus your polio. But this one needs 1 dose of the tetanus, diphtheria, whooping cough as an adult, and then TD every 10 years. And that should be given routinely by family doctors or nurse practitioners. And then the newest recommendation is the Tdap vaccine to be given during every pregnancy. And that is to pass some maternal antibodies onto the baby and have the baby receive some protection before being born. With the outbreaks that have been happening, and even when we're not in outbreak, we always have a little bit of pertussis in the province. So this guideline came out about a year ago. It was in the U.S. first, and then we adopted it. During the outbreak, we were doing pregnant women, but we sort of got back to not being a routine for a while, and now it's back to every pregnancy for females. So that was sort of a new one. So the other one is the measles, mumps, rubella, and it's 2 doses for individuals born 1970 or after. Any healthcare provider or travelers would well, not necessarily travelers, but healthcare workers would receive, have their blood work done too. So it's to have 2 doses of documented, plus to have the immunity show in the blood work. And then something that is in the Canadian Immunization Guide, and with the outbreak, we've sort of been recommending it a little bit more. If someone's born before 1970 and they're not a healthcare worker and haven't had their blood tested, 1 dose of MMR if they're doing international travel, just to be sure. But that would be a private pay. It's not part of the eligibility criteria, so it's not public funded. But it is something that would be recommended. Right now in the province, it's probably a little tight maybe to get that MMR privately, but that should be loosening up again soon. And it could be private. We've had to tighten up our public supply, but private might still have some. So the other ones for adults really are the ones when we move into the 65 years and older. So we have our pneumococcal polysaccharide. So they get 1 dose, any adult 65 and older. But then anyone with a high-risk condition, and there is a table 2 in our eligibility criteria, they would get 2 doses. So that's different individuals, people, suppressed, heart conditions. There's a list there of who would receive that 2nd dose. Second one's always given at least 5 years after the first, and then that's it for life. They don't end up getting a 3rd. It's a question that's come up many times, and there's a theory that with that 3rd or 4th dose, it actually has less of an immune response. So if that particular product is cut off after the 2nd dose. We do have pneumococcal now for babies as well. It's a conjugated vaccine, so it's a little more stable for the babies, but then the adults get the polysaccharide, so it protects against 4 types, 23 types, where the babies is 13. With the 13, the Prevnar 13, some people with high risk also get that, so some adults would get that first, and then the polysaccharide on top of that. And then, of course, influenza for everyone 65 and older.
Staff at the health personnel, if you have available wheelchairs in your department to be picked up, please contact the volunteer desk at 7530. If you have available wheelchairs in your department to be picked up, please contact the volunteer desk at 7530.
Right, and so then the influenza, as I mentioned, everyone's 65 and older, and then there's lots of groups there that are also part of the publicly funded. So anyone up to age 18, 6 months to 18 years of age, people with chronic conditions, people who live with people with chronic conditions, anyone that lives with a child 5 years and younger are part of the publicly funded. So we really do reach a lot of the population now with our influenza eligibility, and then there's, of course, private companies like Horizon Health that pay for their employees. So a lot of the population would get it, and the Irving industry, a lot of the different companies like that, Department of Education. So we do actually, a lot of people do end up having it covered for them. And then there's just a few adults that end up paying, usually through a pharmacy, I guess. All right, so as I mentioned before, we do have our New Brunswick eligibility criteria, and it is found in the MB Immunization Guide. It talks about what is publicly funded. So it's listed by antigens, it's alphabetical, and then at the end it's this table 2, which is really for high risk. So it's a nice little one-sheet page that physicians or any immunization provider can use to see what is publicly funded. So it has them listed. So people who might have a stem cell transplant, they get revaccinated for everything. So they're pretty much getting everything, as well as immunosuppressed. Some people following different chemotherapies and things like that. But then as you move down, heart conditions, different things, liver, different vaccines are eligible for those individuals. So as I mentioned, it is in the New Brunswick Guide, and I had the link attached there, but I won't open it today. It's probably like a 10-page document, but the last page is that 1 page. I thought I'd mention the adolescent vaccines because they do trickle into adulthood if they miss them in school. So we do have our HPV in grade 7 that individuals can receive until age 27. We used to say once they were done school that we sort of cut them off of that, and then it was, no, we're going to continue to allow if they were born 1995 or later for women. But now they are saying 27 is that age for cutoff there. So our eligibility criteria sometimes is on medical conditions, sometimes it's free for everyone, and then there's times that it's when we started the program, and again, that's because of budget. So with the HPV, it's women born 1995 and after, and males born 2005 and after. So we were able to start males just a couple of years ago, and so they now get that grade 7 as well. And then we do our meningococcal conjugate, ACYW135, and that's in grade 9. Individuals can still receive that up until age 25 if they missed it in high school. One of the other things that Heather mentioned was the live vaccine. So I just listed a few of the contraindications that go with these. So one of the big ones is immunocompromised individuals. Whether it's from a condition or from medications, they often cannot receive a live vaccine. Typically, if they're on something like the biologics, the Humira and things, it's an automatic no. Sometimes we might refer to their doctor and see how immunocompromised or suppressed they are. Sometimes they might be able to get something. If it's a low-dose prednisone for less than 14 days, they can usually receive the vaccine. But if it's longer or anything, we're usually waiting on that. Blood products. Not something that happens all the time, but we do see it, and there's just a time frame between when they have their blood product and when they can receive the vaccine. It's not that it's harmful for them to receive the vaccine, but it wouldn't be as effective. So it's about 3 to 6 months, sometimes 9, depending what type of blood product they received. During pregnancy, we wouldn't give a live vaccine. If someone's had TB testing, so that can interfere, so it can be done the same day, or you wait 4 weeks after a live vaccine to do a test. If the MMR was given after the test, we wait until the test is read, because we don't want to interfere. So that's something we would see with students and things, because they're getting their little TB test and they're getting up to date on their immunization. So we don't do the TB testing at Public Health, so we're always making sure we check to make sure they didn't receive it, and we're messing up that result and things. Live vaccines can be given the same day, or we wait 28 days between the 2 live vaccines. Oops, did I just speak through a whole bunch? Okay, so then there's allergies, and there's not a lot of allergies to vaccines, and it would be really any vaccine, not just live for this. But if someone had an anaphylactic reaction to a vaccine, that's when we might defer that vaccine, any component of the vaccine. But that's something we would do a form and get a recommendation on. The egg allergy was something that in the past, they'd have babies make sure they ate an egg before they had their MMR and things. So research has been done, and that's no longer a concern at all. So we don't need prior ingestion of egg before the MMR. Individuals with egg allergies can really receive most vaccines in a normal setting, including the influenza. The MMRV and the influenza were the two that we sort of give more often, I guess, and we used to be a little more hesitant. But the research has shown that it's been fine. During H1N1, there were a lot of egg allergy people who received the vaccine and did fine. So we are able to do that, but we would make sure we always had our adrenaline and things around. And then if there is something a little more severe going on, we can refer to an allergist, and they will often give like 1/10 the vaccine, and then if there's no reaction, they'll give the rest there. Once they've had it once and we know they're okay, we would then just give it normally in our office or at the doctor's. And that's really for other types of allergies, not so much the egg allergy. The egg allergy, we really are okay to give it, but if it was an anaphylactic allergy, the MMR is fine. The flu, we might want to give it maybe in a little controlled setting, like we might meet them here at the ER if we were going to do that, but it doesn't say that in the Canadian Immunization Guide. It just says routine, but we just like to be a little careful if we were going to do that one, I guess. And then the other little rule with the varicella vaccine, which is also live, is clients are told to avoid the ASA for 6 weeks following, just because of the theory of the rays syndrome. That. So immunization services in New Brunswick. So where can people receive vaccines? So the immunization providers are family doctors, nurse practitioners. Pharmacists give travel vaccines or the flu vaccine, sometimes some other little things. Travel clinics, so we refer to a travel clinic as we do have one here, and then pharmacies. Most pharmacies would do travel vaccines. And then public health, we see children and adolescents, and we also see some adults, but that varies from area to area. So here in St. John, we do see all the Syrian refugees and other immigrants. We can use our language line. It makes it easier for them. The records are a little harder to decipher and things, so we just have a little more time for that. So we offer that service, but it wouldn't be everywhere in New Brunswick for public health. Some have partnerships with community health centers that do that service. When we don't see someone at public health and they don't have a family doctor, we will make a connection somewhere for them to get their vaccine. So if you do run into people that don't have a family doctor or nurse practitioner, they can call us, and we have partnerships within the community, people that we can just refer them for the vaccine. We're not, they wouldn't pick up the patient, but they would see them for vaccines. So then one of the other things is adverse events. So we do see adverse events with vaccines, and we do have a reporting system. Adverse event following immunization is also abbreviated as AFI. And that is to monitor and ensure safety of vaccines. So if an immunization provider hears of a adverse event, someone comes and tells you about it or something, you could print off the form. If you weren't the person administering it, you could take the information, call us at Public Health, and we would do the form. But we do want any serious type of reactions documented so that we can keep track of that. The form is found on the New Brunswick Immunization Guide. There's criteria to follow. So a little redness, a lump for a couple days would not be an AFI, but if it passes a joint, it would be. We had some people with measles-like rashes after the MMRs recently. That doesn't qualify for an AFI because we expect it from 4 to 5% of people. So there's a little list of whether it is or not. If we get something that's not meeting the criteria, we still send it in, and then the province would weed those out as they send it on. So we would do it locally at Public Health. We send it to New Brunswick Province in Fredericton, and then they would send that data to Health Canada. It gets analyzed and weeded out a little bit, and then it goes to World Health Organization. And as I mentioned, that's to really support that vaccine safety. We can reassure parents the side effects are so like nil really with most of them, and we have those data there to let them know if it's 2% or 1% or whatever. The other reason for the adverse event following immunization form is we do get a recommendation from the medical health officer whether they would receive a vaccine again. So if it's something serious, typically it has to be very serious for them to say they wouldn't get a vaccine, and typically it would be like an anaphylactic reaction. Most other things, like a cellulitis or something like that, wouldn't be. And then the last little thing I was just going to mention before we wrap up was just pain management. It is something we encourage at Public Health, and it is through our guides and things. So when someone comes for a vaccine, a new mom, we do encourage them to breastfeed. It really helps there's the hormone, the good feeling hormones from the breastfeeding, as well as that skin to skin that really just helps that baby. And they don't cry as much. They latch back on even if they come off for a minute, and it certainly does help, and the mom feels good about it as well. But then we also do recommend the other 4 things, and one of the guides mentioned the 4 Ps, so I decided to use that. But the pharmacological, so the creams and patches, your EMLA creams, and there's probably different brands. We certainly recommend it to people that come to us that are a little hesitant. It's not something we generally tell everyone, but for adolescents or adults, it certainly can help them through the needle. Psychological, and there's different resources for this because there's lots of different techniques, but some would be deep breathing, just support there from a friend or the mother. Physical, so positioning, how we might position a baby. We cuddle, an older child, we let them sit upright. An adult, we like to have them sit so that if they did faint or anything, they're sitting for that, not going to fall on us. There's also the theory that if you rub the skin below the injection site, it sort of helps. Then when you do the injection, it doesn't hurt as much. And then there's certain procedural things that we know as a provider, so we don't aspirate with immunizations. It's not required, and it's a little less painful if you don't have to aspirate. We inject quickly, and then the most painful vaccine last. So that's something we would always kind of know. Adolescents, it's the HPV. The babies, it's that pneumococcal one. The varicella, the MMRV stings a little bit. So we always leave those ones to the last. I think that was it for my presentation. If anyone has any questions.
I have one question about funding for HPV.
Okay.
If you were born before 2005, but less than 27 years, a male, would it be funded, or do you have to be 2005 and later.
Yeah, it has to be 2005 and later.
Okay, so anyone in their early 20s wouldn't be eligible right now.
That's right.
Okay.
We do have on the Merck site, there's a compassion form, and I'm not sure what all the qualifications are, but someone could apply for that to be covered. I'm not sure if it's income-based or medically needed. I've referred a few people to it. I haven't heard back whether it's been covered or not. And then we always tell people check their Blue Cross and things too. That might cover it.
Thank you.
You're welcome. The other adult one I guess I didn't mention was the shingles too, so that's certainly something we get lots of questions on, and it would be something we'd recommend for adults. The first one was alive. The most recent one is an inactivated with 2 doses. It's not publicly funded. Might be later in the future, and that's one I think it's 6 months apart, the inactivated, so it's 2 doses, but it does have a better effectiveness than the live vaccine did. The live one I think was in the 60s. But with the inactivated, people seem to have some side effects, like just feeling icky for a day or two, sometimes up to a week, I guess, of flu-ish type symptom. So, any other questions?
Yeah, hi. Can you hear me? This is, I'm remote. Can you hear me okay?
Yes, we can.
Okay, it's Marlene. I'm a pharmacist at the St. John Regional. And I get this question quite a bit, is replacing TD. That's I guess can you expand on that a little bit? Where question is I think concerned parents or with newborns or pregnant mothers who are one of their contacts, their friends, have up-to-date pertussis immunization. Is that something that they should be concerned about? And I guess how can they determine if they have had a Tdap, or how does that get rolled out?
All right, so yes, with the whooping cough outbreak, probably about 8 years ago, we did expand it so every adult can get a Tdap publicly funded. So we do encourage it if people haven't had their whooping cough vaccine as an adult. We do encourage it. If they're going to be around an infant, it's really highly recommended. And during the outbreak, the postpartum floor wouldn't even really let people in unless they said they had it. And we do encourage the parents to really encourage the grandparents and any friends, any babysitter, anyone that's going to be holding the baby to get that Tdap. So one of the things they could do first is, as an adult, check with your immunization provider to see if you've had it. If someone was to the ER, we are trying to get all the ERs to just give the Tdap and not the TD so that we get that whooping cough in. It doesn't hurt if you get it more than once as an adult. So even if they did have it twice through the emergency room, we're sort of reassured that that's happening, but we would probably still want them to maybe check the health records because we're not sure, But typically the ERs are using it, but people can get it through their family doctor, and pregnant women can get it if they're going like to the St. Joe's Clinic, the maternal for the women. And then we do have physicians here in our area who will give that to anyone without a provider. So if someone doesn't have a doctor or nurse practitioner and they're wondering where they can get that, they could call public health. We don't really advertise the names, but we give them out quite readily. There's a few, like Dr. Simon does it, Dr. Fisher, there's a few, but it could change, so that's why we don't sort of print that and send it out to people. But we do want everyone updated with their whooping cough for sure for infants, and we do try to encourage it. I feel lately it's sort of diminished a little bit in the community because it seemed before we always, we were hearing that all the time. I can't visit my granddaughter because I don't have my whooping cough vaccine. Whereas now, like last weekend, we did have, there was a case of whooping cough in Fredericton, but they'd been to a little party here in St. John, so we had worked that case up, and there were numerous grandparents who didn't seem to really know about the whooping cough, so that was a little concerning, so I think we have to raise our awareness again with that one.
Okay, great. So for adults getting their 10-year booster, for example, would they be questioned, or would they be automatically given a Tdap in this, depending, I guess, I suppose it depends on their age.
Yeah, if they went to their doctor, hopefully the doctors would just be giving Tdap, unless they were sure they already had it. But because the outbreak was 8 years ago, most wouldn't have had it or wouldn't be due again for another dose, where it's every 10 years. But I do find doctors and nurse practitioners aren't always thinking about that TD. So many adults, when we say it, they're like, oh, I wouldn't know when I had my last tetanus shot unless you bit or cut and you went to the emergency room. So we do encourage adults to reach out to the doctor if they're not mentioning it.
Okay. Thank you very much.
You're welcome. They should be given the Tdap, but like I would imagine most would have the Tdap.
So check is the bottom line. They need to double check.
Yeah, we need to kind of reach out to those doctors and check on our file. And some are probably better than others at getting their patients up to date, but it's one of the ones that isn't as effective as the rest. The whooping cough one's about 80%, so we still need everyone really protected well to get that community herd immunity that we look for. All right, any other questions? Well, thank you for having me, and if people do have questions, feel free to call us. We're happy to talk with any person in the community, any healthcare provider, and try to get the information out. Spread the word.
Thank you very much.
You're welcome.
Thanks, everybody,
Thank you.
for joining.